But I was asked to kind of give a little bit of an update in lipid management and some of the new therapeutic medications and the ones that are out. And actually, the latest update is now we have some at least top line results on bempedoic acid. Some of you may know this as Nexletol. So I guess without further ado, I'll kind of march us through this. Let's see if I can. Okay, so some disclosures. I do receive some grant research support from Janssen Pharmaceuticals that doesn't really touch on this, as that's peripheral arterial disease. I am a sub-investigator on several of the studies that have led to FDA approval on some of these medications. So, learning objectives, I was hoping that we would review a little bit of the guidelines, primary and secondary prevention of ASCVD, kind of give us a baseline and foundation to start from. We'll talk a little bit about statin-related side effects, how to manage them if possible, and also just review the current lipid-lowering agents. So from that standpoint, I'd like to stop for a second and just have you think about this. Do you currently consider adding non-statin medications to patients who have atherosclerotic cardiovascular disease? Never, rarely, sometimes, frequently, always, not applicable. You don't prescribe. You don't, treat ASCVD patients. And when I say non-statin, it's everything else but the statins. If you'll recall, in 2013, folks kind of got the sense that statins really were the only medications out there with great data on reducing events, and all the other non-statins kind of were brushed off until the 2016 update. So another thing to think about that we'll touch upon in this talk is ASCVD patients. What about those that you have an LDL cholesterol that's managed? And we'll talk about what that level is, but the triglycerides are greater than or equal to 150. Do you do something with those individuals? Again, never, rarely, sometimes, frequently, always, or not applicable. I just want you to kind of think about those two questions, and as we move forward, hopefully I'll change your mind and you'll think maybe I should be more frequent or always you'll address these issues. So, guidelines. I love this GIF. We have evolved. Or have we? You think of the lipid guidelines, and of course we're US-centric, or I'm US-centric anyways. There are the European Society of Cardiology guidelines, and actually within the US we have the American Academy of Clinical Endocrinologists. Just recently, there is parity with regards to LDL cholesterol thresholds or goals that we want to reach. But it's really been all over the place, and even in 2018 when the cholesterol guidelines came out, again, the updated ones then, within the same conference meeting, actually the next talk, icosapent ethyl was addressed, and REDUCE-IT study was presented by Dr. Deepak Bhatt, and so it almost threw the guidelines out of contemporary helpfulness at that point, because we weren't addressing triglycerides. So when we think of the 2018 guidelines, American Heart Association, ACC, management of blood cholesterol, I just like to think of it as two paths. It should be as simple as that. There's primary prevention, folks that have not had an event, and then secondary prevention. So, what is that? Well, people who've had an event. So let's break it down a little bit. But before we go there, remember, there was a big switch from the statins and non-statins to just statin therapy in the 2013 guidelines. And I love these graphs. So if you look first on this left side, I just want you to look at the event rate here, up to 30% events down to 0, and then what the lipid cholesterol levels, LDL cholesterol levels were. Up to 190. And folks should be familiar now that when we see 190, we should be suspicious of familial hypercholesterolemia. But the 4S trial, this was, early to mid 80s, looking at the 4S trial, they were enrolling people with an LDL cholesterol 190. They were basically FH patients. But look what happens when you treat with a statin and it drops the LDL cholesterol, but it also dropped the event rate. I mean, think about this, right? The event rate, this is annualized. They were up around 26%. And then dropping them down into below the 20% line. And then with each subsequent study, as we look at statins and then looked at higher intensity and then statins versus statins, high intensity versus low intensity, what you see is that every single study, the more intense you were with LDL cholesterol lowering, the higher the dosing, and there was a massive drop in events. So from the 4S group all the way up here, 26% down into 6% range. It's amazing. And so what we should think about is in the statin versus no statin, for every 38 milligrams per deciliter drop in cholesterol, there's a proportional drop of MACE events by about 20%. So 38 to 20%. And that's in the first year. Well, it's not like you have a cold. When you have coronary disease or you have risk and you have events. So you continue the statins, and for each subsequent year, as you continue on, you can have a further reduction, about 5%. So overall, 25% reduction in events as you continue statin therapy. Now, it holds true if you go from like a light, lickable doses of statins to actually taking a statin dose that makes sense. Then what we see is you have an additional decrease in events going from just a light dose to a higher intensity dose. So the bottom line here is just down there at the bottom. A high intensity statin, we'll talk about what those are. For each 50 milligram per deciliter drop in cholesterol, there's about a 28% drop in MACE events. So, I think that's the first and foremost lesson here, that the 2013 guidelines really nailed is statin therapies are first line, and there's a reason for it. So here are the definitions of statin intensity from left to right. You can see high intensity statins. Really, what makes a high intensity versus moderate versus low is the percent reduction in LDL cholesterol from baseline. So if I had a 200, or in the 4S trial, if I had 190 milligram per deciliter LDL cholesterol, if I started with an atorvastatin, either 40 or 80, or rosuvastatin, 20 or 40, I would expect to see at least a 50% reduction. So from 190 dropping down to 80 milligrams per deciliter. So, or somewhere down south. And those are the two that you have to think about. Atorvastatin and rosuvastatin are the only two statins that have high intensity dosing. All the rest are moderate intensity or low. And it's okay to think about these because, folks, not everyone tolerates high-intensity statins. And so you have to try lower doses or alternate regimens, every other day, every third day, etc., to get some statin on board. Because it's not just LDL cholesterol lowering. Statins have a pleiotropic effect, which we won't address here, but just know that there's an important mechanism that statins supply beyond just LDL cholesterol lowering. So when we think of secondary prevention, that's the easier one, I think, to address first. So of those two roads, as we branch off to the right here, secondary prevention, what's an ASCVD event? Well, heart, right? I mean, most of us are honed in on coronary events, acute coronary syndromes, myocardial infarction, but don't forget brain attacks, right? Ischemic stroke. And then finally, peripheral arterial disease. So the lesson here is anything atherosclerotic in our arteries will give us a diagnosis of or at least a paradigm of treatment for secondary prevention. So what's the goal here? Well, at minimum, statin, please. The first goal is really a greater than or equal to 50% reduction from baseline. I think most of us are like, well, no, the first goal is less than 100 or less than 70 milligrams per deciliter. But actually the trials and the guidelines are clear that the first goal is to achieve a 50% reduction of LDL cholesterol. That's it. That's the first minimum goal. And then you think about thresholds after that. So again, the high intensity statins are here, atorva and rosuva with their associated doses. And then the 2018 second goal was to achieve an LDL cholesterol of less than 70. So that's kind of, you start a statin in the person like myself. If I had 190 and I did a atorvastatin or rosuvastatin 40 milligrams, and I was still above 70 milligrams per deciliter, that should clue you in that I need something else, a non-statin therapy, to get down below 70. But we'll talk about the new guidelines in terms of the thresholds, because the updated expert consensus decision pathway that was just released in September of this year is, and I'm sorry, it's a lot of verbiage. I should have kind of broke this down a little bit. But folks that are not at high risk, meaning they didn't have a STEMI just in the past 12 months or an NSTEMI, and they're not over 65, they don't have diabetes, etc., then you're still shooting for an LDL of less than 70. But I venture that most of our folks that have an acute coronary event are at very high risk. These are folks that are already above 65. They have concomitant disease like diabetes, hypertension. They may have a BMI that's over 30 or 35. Then their LDL cholesterol goal is actually less than 55. We've learned a lot from the PCSK9 trials with regards to how safe going very low is. So this is a complicated slide in the sense that it will build this out, but I want you to fall towards the left here in clinical ASCVD, folks that have had a stroke, peripheral arterial disease, or a heart attack, but not high risk. They're not high risk. They've had an event, it's been maybe 4 or 5 years, so always healthy lifestyle. But then what do you add, right? So we always start at healthy lifestyle. We're going to talk about nutrition, physical activity, those kind of things. But everyone should be considered for a high-intensity statin therapy or maximal statins. So just remember that's the key here for prior authorization. Some people, you've tried 2 or 3 statins, they don't tolerate any of them, so the maximal statin is actually 0, and that's when you start thinking of non-statin therapies earlier. Here, first goal, greater than 50% reduction in LDL cholesterol, and then you think about LDL cholesterol dropping to less than 70. Again, this is the not at high risk. So greater than 50% reduction, and then achieving an LDL cholesterol less than 70 milligrams per deciliter. Now, if they didn't or they haven't, then you should consider a non-statin therapy. And we'll talk about what the algorithm here is, because the first is ezetimibe. I see a lot of patients in my lipid clinic where they're referred, and often the referring provider will say, well, they weren't able to get to less than 70. And I look, and, well, they're just on a high-intensity statin therapy. You can't get any higher than atorva 80 or Rasuva 40. And so the obvious answer is to at least try to initiate ezetimibe. Now, and we'll talk about the ezetimibe's mechanism and how much further it reduces cholesterol, but sometimes you're still not able to achieve a 50% reduction from baseline or even an LDL cholesterol of less than 70. So if that's not the case, no, you come back to the stop. You don't stop ezetimibe. You say, okay, what else do we add here? So now you have statin, you have ezetimibe, and you come back down to the algorithm to, well, maybe we try a PCSK9 monoclonal antibody. This would be, the brand names are Repatha and Praluent, or evolocumab and alirocumab. Again, you're going to ask yourself after initiating this, statin, ezetimibe, you've got Repatha or Praluent, and have you achieved an LDL cholesterol less than 70 and at least a greater than 50% reduction from baseline? Generally speaking, I haven't seen too many people not achieve either one of those when you have a statin, ezetimibe, and a PCSK9 monoclonal antibody. But for those that don't achieve it and or are statin intolerant, so let's go back upwards to this first bar where the maximal statin was no statin at all, then you may consider bempedoic acid sooner. along with ezetimibe. And we'll talk about bempedoic acid. And the key here is that it's been studied for those folks that are statin intolerant. Now, inclisiran was just recently FDA approved in the States as Leqvio, and that's the twice a year injectable. It also targets PCSK9, but from a different mechanism. Again, you're going to ask yourself, did I achieve a greater than 50% reduction or an LDL cholesterol less than 70? Now, if no, at that point it gets a little tough because you should consider, I'm the lipid specialist, but I don't do plasma apheresis. I would get you in touch with my colleague here in Salt Lake, if you were here, would be Elliot Brinton. He's the only person that does plasma apheresis for lipids in the Western area. So that's where you would go along with these other medications. I would refer you to him for plasma apheresis and also to a dietitian as most likely, and I'll tell you now, as someone that's practicing in cardiology and as a lipid specialist, I have gone and seen a dietitian as well, and in fact still see a dietitian. So what constitutes very high risk? What's that other side, that empty side that we hadn't filled out? These are folks that have had multiple major events. So maybe they've had a heart attack 5 years ago, then they had an ACS where it was unstable angina. 2 years later had stents or stent thrombosis, or they had a bypass and had to have a stent in saphenous vein graft or the lima. That's very high risk. Something's happening that they're having progressive events. The major events here, certainly anyone that's had a recent acute coronary syndrome less than 12 months, history of MI, plus these others, so it can be beyond 12 months, but it has to be inclusive of some other event as well. Stroke, peripheral arterial disease, plus these high-risk conditions. So someone over 65, as I mentioned, heterozygous familial hypercholesterolemia, that's what HEFH is, history of bypass, along with a heart attack, and then all these others here. So, as I said, I submit to you that most of our patients probably are very high-risk ASCVD. So let's come back to this. Clinical ASCVD, healthy lifestyle first and foremost, always. And then as we go to the very high-risk ASCVD side of things, then, again, high-intensity statin. And you should be able to say now, okay, Viet's going to ask me, what's the percent reduction that has to be from baseline? Greater than 50%. And then what's the achievable LDL cholesterol? Well, it's different now, right? It's less than 55. So it's no longer 70 as the bar, it's 55 milligrams per deciliter on maximally tolerated statin therapy. So then you're just going to walk down that same algorithm and say, well, did they meet it or didn't they? If they did, you're done. You're not going to abandon them and say, well, set and forget or fire and forget. You're going to continue to monitor folks. But if they didn't off of statin alone, then you're going to look at that same non-statin algorithm. Again, here you have the capability of going ezetimibe or PCSK9 monoclonal. And I've done both at the same time, especially in folks that I know already that ezetimibe, a further 20% reduction is just not going to cut it to get down to 55. It's tough. It's tough to do so. So I'll start them on both. Otherwise, you analyze them again and say, well, did we get a 50% reduction and did we achieve LDL cholesterol less than 55? If not, then we're coming back up to the algorithm and say, okay, what else can we do? Now we know that there's bempedoic acid and inclisiran that's available, but you cannot add inclisiran to a PCSK9 monoclonal antibody because they affect the same target, PCSK9. One just happens to be a monoclonal antibody that you inject every 2 weeks. The other is a small interfering RNA, that's inclisiran, that you inject twice a year. So it's either or for those, but you could add the bempedoic acid and then again assess whether or not they've met the greater than 50% reduction and achieved an LDL cholesterol less than 55. Again, if they haven't, then consider referring to a lipid specialist, and really at that point they probably need plasma apheresis, which is not a small thing. I mean, think of dialysis, but instead of 3 to 5 days a week, it's still probably once a week or once every 2 weeks that you're doing. You're hooked up to a similar hemodialysis type machine, and then referral to a nutritionist. Okay, so this is what it looks like. I mean, it's so busy when you look at it all together, but hopefully it makes a lot more sense now, pathway of not high risk and then very high risk, and how we move down the algorithm. Okay, so I'm just going to do as a reminder, it's a little bit easier on the eye here. Secondary risk reduction, as you went off that right path, there's stable ASCVD, high intensity statin therapy is always first and foremost, along with lifestyle, and then the very high risk ASCVD, again, high intensity statin therapy. So it's kind of a no-brainer. You always start with a high intensity statin therapy, but the goals are a little bit different in terms of LDL cholesterol reduction. Certainly everyone should have at least a 50% reduction from baseline. So here, again, I kind of started with the main view here, and I apologize. It is busy when you look at it this way, but this is the primary prevention, okay? All the green are the main areas where you would target statins to. Here, the blue for diabetes, instead of moderate intensity, you're moving to high intensity, but it's class 2A. So the green are class 1, meaning as a recommendation, absolutely you should think about this. It's recommended, not just consider it. In a class 2A here in the diabetes, you can say, well, should we actually march forward to high intensity? The data says that it's a good idea, but we don't necessarily have to do it. Okay, so primary, I guess I should talk about this a little bit. It is busy, and I should have broken it down again for you. So let's start at the beginning. These are folks that do not have any diabetes and no coronary disease. And what you should remember is that as we think of age 0 to 19, I work in adult cardiology. So I do not see these patients that are less than 19, actually less than 18 years of age. But from 0 to 19, the American Academy of Pediatrics does have guidelines that say they should have at least a lipid once, but actually twice. One when they're younger, less than 5, and then or less than 9, and then again when they're in their teens. And believe it or not, LDL cholesterol can be just astronomical if they have homozygous FH in the 600, 700 range for LDL cholesterol, but for heterozygous, it can range from 120 up to 200s. It's not a lifestyle issue for them. This is a genetic mutation. Then 20 to 39, you should be also evaluating and from time to time doing an LDL cholesterol or lipid profile. Certainly, if they have an LDL cholesterol greater than or equal to 160, they should be on your radar. It's not normal. Something else drives that beyond just lifestyle itself. And then this is the group that I fall in, 40 to 75, and an LDL cholesterol that's above 70 but less than 190. No diabetes. And this is where we talk about the pooled cohort equation, or ASCVD risk score, 10-year risk score. If you haven't encountered it by now, feel free to look in Google and type in ASCVD risk score or calculator, and you'll be directed towards the acc.org. So these are the categories. Less than 5%, most likely you can kind of leave alone and do lifestyle. 5 to less than 7.5%. These are the borderline risk folks. You should have a risk discussion with them. Just age alone. If you're 50 and you're at less than 7.5, the next year you will cross that threshold into the next risk group. But these are the enhancements that you should be thinking about. Someone that has a family history of premature events really should ring a bell for you. You should be thinking, I should pay a lot more attention. We should have some education here. Again, LDL cholesterol greater than or equal to 160, and then all these others. Now, at the end, you may have some questions with regards to, should you do HSCRP? I do it with everyone. LP little a, yep, we should probably do that once in someone's lifetime, and ApoB, which is where I gravitate towards, and we'll describe why. But this is, by and large, the bulk of the folks that we see are the intermediate risk, who are statin eligible. So that's really what we're doing with the guidelines, is understanding who's eligible for risk reduction. And that's this group, and of course the high risk group, where we're going to start a statin. Diabetes, it's very simple. Anyone with diabetes between the ages of 40 and 75 should be on a moderate intensity statin. And then, of course, the LDL cholesterol is greater than or equal to 190 should give you a hint that this, while they may not be positive for a genetic mutation, their risk is around 3 to 5 times higher than the normal population. So they may not have heterozygous FH, but something's driving that LDL cholesterol to be greater than or equal to 190. That's not lifestyle by itself. So they are at risk and should be on a high intensity statin. Okay, so that group, this is it right here. These are the adults that have not had an event, but their baseline LDL cholesterol is greater than or equal to 190. As we walk just quickly down this, maximally tolerated statins. Again, the goal is to have a 50% reduction, but instead of 70 or 55, we feel mostly comfortable to get them their LDL cholesterol less than 100. And if not, then you're just going to come back through and, okay, what can we modify further with lifestyle? Are they adhering to guideline-directed therapy? What other risk factors? Do they have diabetes? And then they kind of get bumped into the diabetic algorithm. But these are folks that truly could quickly go to high-intensity statin from moderate. But the algorithm's no different down here, because you want to make sure they have a 50% reduction, and then did they meet their goal of LDL cholesterol less than 100. If not, in any one of these areas, you can try ezetimibe, PCSK9 monoclonal, bempedoic, or inclisiran. And then now with heterozygous FH or homozygous FH, you may consider evinacumab. I've not prescribed evinacumab to date. I've not found a homozygous FH, and I've not used lamidipide either. But there are folks in our community that have been referred to Elliot, Dr. Brinton, for LDL apheresis. So just remember that they're at very high risk for events. 1 in 3 women under the age of 60 will have an event. 1 in 2 men under the age of 50, if they have heterozygous FH, will suffer an event. Over on this side, the primary prevention diabetes, again, it feels like there's a lot to look at here, but the algorithm is very similar. It follows the same flow. They should be on a moderate intensity statin therapy. Consider calculating their risk to see if they should go to a high intensity statin therapy. I mean, when we have patients that have diabetes, there's a lot you're managing already, and so it's kind of hand in hand. Anything you do for the diabetes, you're really also treating for lipids, and vice versa. You're trying to impact all the sequelae that come with diabetes. So here, if they're greater than or equal to 7.5%, if you end up doing a 10-year risk score with them, then yeah, you should really consider high-intensity statin therapy. Certainly if their risk is greater than or equal to 20% on scoring, then same. I mean, you should shoot for a high-intensity statin therapy, but your goal is now changed to achieve a less than 70 milligram per deciliter instead of over here where it's less than 100. So just realize that these slides, and I don't know, we can make these available, I think, and Sharon will correct me there, but I guess if folks reach out, we can certainly give some of these slides out. So in context here, here's the primary prevention treatment and their escalation. Again, you have the diabetic side, and then LDL cholesterol greater than or equal to 190. I purposefully did not place the 40 to 75-year-olds without diabetes and that have an LDL cholesterol less than 190 because, again, they start with moderate intensity statin therapies. And there's not a lot of escalation because there's not an LDL cholesterol goal there with those individuals. Okay, so as kind of compiling everything back together, what is primary risk? Well, these three green boxes encompass those populations. Diabetes 1 and 2, and then it's broken down, stratified by age. Here, so 20 to 39 with a long-standing or risk enhancers. Diabetes by itself, 40 to 75. And then folks that are 50 to 75, they elevate in risk automatically and have high-intensity statin therapy. Here's the 40 to 75-year-olds with no diabetes, no coronary disease, LDL cholesterol is less than 190, and then what their 10-year risk score would have us recommend in terms of therapies. And then finally, LDL cholesterol greater than or equal to 190. So this is the cheat sheet, and this is where you should start, but I wanted to make sure that you understood how to incorporate non-statin therapies and how to think about those. And so the prior slide gives us a better sense of that. Well, not everyone is able to tolerate statins, and the question is can we identify those that are at risk for statin-associated muscle adverse events? What are those? Myalgias, myopathy, myositis, myonecrosis. Yes, people can have destruction of muscle tissue. Certainly rhabdomyolysis, which is, CKs that are massively high, and dark urine, those kind of things. I've only had that once. Not me personally, but a patient that in my clinic, in 19 years of practice, only one had rhabdomyolysis, and they stopped statin. That recovered, but we never reinitiated statins, as you can imagine. But in this day and age, this is not common. It's not common at all. Now, risk factors for myalgias and myopathy. This is the list, and the question here was answered: does vitamin D supplementation help? Well, it turns out it doesn't, or at least at the dose that they gave in the most recent clinical trial. I have thoughts on that, but at least from 2,000 international units, doesn't seem like that's helpful in reducing statin-associated muscle adverse events. So, if they have myopathy with other lipid-lowering therapies, chances are it may transfer over. I still find it odd when folks have myopathies with ezetimibe, only because the mechanism has nothing to do with skeletal muscle tissue, whereas statins do have receptors in our skeletal muscle. But you can kind of see here what would place someone at risk. It's real. It happens, and I believe it when patients tell me, and I don't poo-poo this. I don't tell them, oh, it's all in your head. Folks, people have statin myalgias, and it's question is how do you work around it? How do you help them through it? And in the end, it's a benefit-risk ratio that the patient has to decide. You don't get to decide that. We just give them the information, but patients get to decide, am I going to be miserable every day with the statin, or do I feel okay with at least exposing myself to some risk not being on a statin? That's not our choice, but we have to make sure that we navigate that for them. So statin intolerance, here's the management through NLA guidance. So the National Lipid Association did give some guidance on this, and I like this. You can kind of tuck this above your computer, as how do I go about this? Well, sometimes you just got to suspect it to begin with, and then work backwards or work low and forwards. So instead of saying, well, we're done with that, I would say, well, there are different classes, not different classes, there are different types of statins, and certainly if you're having symptoms with one, doesn't mean that you have them with all. Often in the old days of treatment, we would go right to pravastatin. But I would actually tell you that most of my patients tolerate rosuvastatin better. And then I fall back to pitavastatin if necessary. But Rasuva has a longer half-life, and typically you can get lower doses and then go out to once every other day, once every third day, and see where they're at. And then just kind of titrate to tolerance. And at that point, you can then get a lipid profile and say, okay, can we add ezetimibe? Can we add PCSK9? Or, do we go to bempedoic acid? But here you should consider the nocebo effect as well. What is nocebo? Nocebo is the idea that you feel symptoms because you were educated that there are symptoms to be had. I would argue that Google is for good and bad. I don't discourage my patients from doing their own internet searches. I just ask them to talk it over with me before they make any type of decision on their own. But we'll talk about the nocebo effect here in, I think, the next slide. So what is it? Again, negative preconception increases the propensity, the potential for adverse effects and symptoms as experienced by humans. Now, there was a trial called the SAMSON N of 1, and what they did, and this was in 2020, it was quite elegant, I think, in how they came about this. These were folks that had already reported statin intolerance. So they already had this experience of being statin intolerant. It was 60 patients, not a big group, right? So you can only generalize this so far. But it was 4-month periods, full quarters of the year of either no medication, so they didn't receive anything, or for 4 months they received a placebo. They were on medication that wasn't a medication. And then for 4 months they were on atorvastatin, 20 milligrams. And boy, this was it was astounding what the data was. So when they got to the end of the trial, what you find is that for those that reported symptoms, remember, placebo controlled, 90% of the time the symptoms were elicited with placebo just as they were elicited with statins. So for the 4-month period that they were on placebo, they reported symptoms 90% of the time as well. And when patients were shown this, they were like, okay. So half of them decided to restart statins again because they recognized that, well, they had symptoms on this placebo to the same degree, same severity as they reported with the atorvastatin 20. So they agreed to restart, and actually it was successful for those 50%. So it's a nice trial to explain and use and discuss with patients. I don't use it to browbeat folks. I just let them know, look, there is this real nocebo effect as well. And so at least it's encouraging that perhaps we can move forward and trial a statin again. So let's take this case study, right? Mike he's 66. He has had a bypass. He's 54. He's taken aspirin, sporadic exercises. But look at his baseline LDL cholesterol, 270. So it should sound a little familiar to a patient type that I've talked about. But he does have type 2 diabetes. He's taking metformin 2,000 milligrams a day. But boy, your radar's already up with this LDL cholesterol. He has family history of premature events. His father died of an MI at the age of 46. So when you're looking at his lab values, you're like, okay, what do I do with this? Well, he's on rosuvastatin 40 milligrams, and as we would expect, it cuts it in half, right? LDL cholesterol 135 from 270. And if we followed our algorithm, first of all, Mike, he's very high risk. Right? He's over 65, he has diabetes, he's had a bypass that was associated with an MI. And so we would want his LDL cholesterol less than 55 milligrams per deciliter. But he at least hit the first minimum goal of dropping by 50% from baseline. So when we think about this, and I love to calculate this for patients, I let them know, they always think I'm magic, but I tell them it's just what's expected. Now, folks can have a poor effect with statins versus a hyper response. But in general, when you calculate and you say, look, your baseline is such and such, I expect to see at least a 50% reduction, so I give them that, and I say I would love to see it just drop right to here. This gives you a chance to talk about up front with Mike or whomever that perhaps atorvastatin won't be enough. You may have to, or rosuvastatin may not be enough. You may have to add ezetimibe, and they may also need to be on a PCSK9 inhibitor. So you way at the front, that you're just telling them the reason why we're lowering cholesterol is this. The way that we do that is this. And based on these medications, most likely this is the path we're going to go down. But if you're reluctant, let's just start with Rasuva. This is what I expect. And then it builds credibility, and they realize, okay, Viet's probably right that ezetimibe will only reduce this by another 20%, and that most likely PCSK9 will get us to where we need to. So we need all three. So which medication, he's on rosuvastatin, what would be the most appropriate, knowing what we know with the algorithm, to add to Mike's regimen to reduce his LDL cholesterol and his ASCVD risk? So you have bempedoic, evinacumab, ezetimibe, and inclisiran. So I'll give you a second there to think about it, and here we go. It's ezetimibe. Okay, so evinacumab, again, is homozygous FH, bempedoic acid. He's not intolerant to statins, and that's second line, and inclisiran, again, is also in that second line therapy. So as we think about this, it looks like a busy slide, and I will tell you that this is the figure that I use with all of my lipid patients. I start here, and they get it once we go through this. So I talk to them about this exogenous pathway, what we eat, and how that affects our cholesterol versus the endogenous within us. Then I talk about how that food gets emulsified. It creates micelles, but it has to be absorbed through these NPC1L1, Niemann-Pick receptors. That's where ezetimibe works. And that those micelles then get brought in and get stamped originally with ApoB48 and become a chylomicron. So then those chylomicrons are broken down a little bit further into these remnants that we can use in our muscles or in the adipose tissue where we store it. I've got a little bit of that. And ultimately they can come up and come in through this receptor, ApoE receptor, and that's the pathway here where we begin to create cholesterol that we know of traditionally. So LDL, VLDL, all of that. As it picks up ApoB100, then here is where we develop the traditional cholesterol that we recognize, VLDL, IDL, LDL cholesterol, etc. But ApoB defines all of those cholesterol components here. That's why we're finding ApoB is a better risk prognosticator than LDL cholesterol, because ApoB defines all the cholesterol, not just LDL cholesterol. So then I walk them through this same slide or the same figure on my computer, and we talk about what ezetimibe does, how it blocks cholesterol absorption and reabsorption. We talk about bile acid sequestrants, which I don't use unless I end up with treating a patient that's of childbearing age and is actually pregnant. We stop the statins and go to bile acid sequestrants. But then bempedoic acid over here, earlier in the cascade before statins, and then PCSK9 inhibitors over here, the monoclonal antibodies. And of course that is also where inclisiran works, but as small interfering RNA. So it stops PCSK9 proteins from being made. So I walk patients through that during a consult. I kind of have the time. It's not 15 minutes. I usually spend 45 with my patients. But here again is another way to look at those non-statin lipid-lowering agents. Again, bempedoic, statins, ezetimibe here in that NPC1L1, and then inclisiran and PCSK9 inhibitors over here on the far right. So thinking about non-statins, I might have to move a little quicker, I apologize. But ezetimibe then is really for primary and secondary prevention. PCSK9s, here, the monoclonal antibodies, evolocumab and alirocumab, or Repatha and Praluent, can be considered for primary prevention, usually with people in folks that have LDL cholesterol greater than 190, but generally secondary prevention. And then bempedoic acid and glycerin also currently are FDA approved for those that are FH, familial hypercholesterolemia, so LDL cholesterol greater than 190, or if they have an ASCVD event. And then in terms of LDL cholesterol reduction, these are the general guidelines, or at least our guesstimates by clinical trials of the range for LDL cholesterol reduction when you use, like for me, I go to colisavilam for my patients, but ezetimibe 18%. I typically quote 20%, and that's what I've seen in my patients when I use it. Bempedoic acid is about 17 to 18. So it's very similar to ezetimibe. And although I had clear outcomes trials expected later in 2022, they've already reported top-line results. And so we hope to see those at ACC 2023. Here's monoclonal antibodies. Again, these are the PCSK9 interfering medications. Whether it's a small interfering RNA or a monoclonal, they get very similar LDL cholesterol reduction. And then the trials here, Odyssey and Fourier, so there's cardiovascular outcomes. For inclisiran or Leqvio, we're still waiting for those trials to report out. I'm still enrolling for Victorian, and Orion is also still enrolling. So hopefully we'll see some outcomes, but we're part of both of those trials here at Intermountain. So Mike does come in. He's been on atorvastatin. Somehow he switched from Rasuva. LDL cholesterol is now 100 milligrams per deciliter. He's walking. He's trying to figure out things. But gosh, we weren't quite paying attention. We discover a tendon xanthoma. And that's a thickness that's occurring around a tendon with this premature ASCVD, the baseline LDL cholesterol, and this xanthoma, we suspect heterozygous FH. And the reason why we worry about that is because his progeny, not him, but his siblings, his children, we can do cascade testing and identify those folks. But here, his LDL cholesterol, let's just say it's 110, and we want to add a PCSK9 inhibitor, but he wants to just do diet and exercise. Now, this will come up, right? I think it's okay. It's okay to I don't think it's okay. It is okay. From a shared decision-making process, patients need to be in charge of that. We're just navigating for this. But I think we set a deadline to help him figure out, okay, what are the parameters here in terms of starting a PCSK9 inhibitor. And that's what I think is appropriate, is say, try some diet and exercise if you'd like. I'm going to root for you the whole way, but at the same time, within 3 or 4 months, we'll know whether or not those changes are going to work by themselves anyways. So here, PCSK9 inhibitors, if you've not used them before, they're injectables. They're a pen, so you don't have to use a syringe. It's very much like an EpiPen. You just put it up against your skin, click, and it's a very small gauge needle. Most of my patients tell me they don't even realize that it is actually dosing them after they've clicked the pen. But you can see the dosing here. Starting dose is 75 versus 140, and then increasing this if they happen to have homozygous FH. Here, what do they do? These are monoclonals, so they don't last long. What they do is these antibodies stick onto this PCSK9 protein. So this PCSK9 protein is basically sticking onto your LDL receptor. That LDL receptor, just like it says, receives LDL cholesterol, brings it into the cell, and gets rid of it. I tell my patients it's the garbage truck of the body. It's picking up LDL cholesterol, bringing it into the landfill, dropping it off, and coming back out to pick up more. but PCSK9 is kind of your overbearing manager that micromanages everything and then fires you after you do a good job. So we want to somehow interfere with PCSK9 so that it's not messing up the garbage truck. And that's what PCSK9 monoclonal antibodies do. FH, just quickly here, it's one of the most common cardiovascular mutations or diseases, and it's estimated about 1 in 200 in terms of prevalence. For homozygous, it's not as prevalent, 1 in 160 to maybe 1 in 360,000. I mean, these are folks, again, with LDL cholesterols that are in the 600 to 1,000 range. They typically have MIs in their teens to their early 20s. Refer for those folks. They'll need apheresis and other high intensity type lipid lowering therapies. But just as a visual, in the general male population, the risk of an MI at the age of 50 is really about 6%. In an untreated FH male, 1 in 2. So instead of 5 to 6%, they're at 50% risk. Women that in the general population less than age 60, about 5% will have an event. But an untreated FH woman has a 1 in 3 chance of having an event. So it's something we need to pay attention to, and that is important to how we manage our patients. I'll kind of breeze through this because I want to get to the mechanisms of therapies here. So inclisiran here, again, this is a small interfering RNA. It works on PCSK9. This is the protein, and so you can see evolocumab and alirocumab, Repatha, Praluent, how they affect PCSK9. But what inclisiran does is it works much earlier. And as a small interfering RNA, it says, you know what? Don't graduate that manager from whatever business school it was that they learned to micromanage. I'm kidding, but don't create PCSK9 to begin with, and it lasts up to, the effect can be up to 6 months or longer. But it's only for those that are secondary prevention or heterozygous. All doses are given in clinic or hospital by clinical staff. These are not self-injected by patients and not at home. So actually it's an interesting way that Medicare pays for this through Part B and not through Part D benefits. How do you initiate it? Well, you give a baseline injection, and then 90 days after that is your second injection, and then once you've initiated that cycle, it's every 6 months thereafter. So you don't have to do a baseline and a 3-month. It's just 6 months after that. But I mean, what happens if patients miss an appointment for an injection? The cool part about this is you have a 3-month window. I mean, think about that second injection at 3 months. You have all the way up until the 6th month to give that injection if they missed it. Or you have another 3 months in between there before you have to give that injection or start over. So if it's less than 3 months, you've got that huge window. And I actually have patients just call and schedule, and my MA gives it the injection if it's outside of a visit window with me. So that's a great part about it. But the efficacy here is amazing. The percent change is, as you saw, is about 50 to 60% reduction in cholesterol, and the absolute change here you can see is anywhere from 50 to 60 milligrams per deciliter versus the placebo group. So I think here the main learning point is that we don't have outcome trials yet for inclisiran, but those trials are being done. Dr. Anderson and myself, we're sub-investigator. He's the PI at our site, and it's very exciting, folks. So when we look at the subgroup analyses for percent change, you can see that through all groups, doesn't matter what age, what BMI, what race, all of them have a large, basically it's equal reduction in LDL cholesterol. So you can use it in any population. Bempedoic acid. Here is where the Clear Outcome study has given us top line results. But bempedoic acid also, you'll probably have heard of it as Nexletol. With ezetimibe, it's called Nexlizet. Ezetimibe. Anyways, the indication here is ASCVD and heterozygous FH. Although it's been studied as a medication to be used in statin intolerance. So I think that's where its best niche is in folks that do not tolerate statin therapies. Then you can use bempedoic acid. I like to use Nexlizet because then I can just take one pill, and that covers both bempedoic and ezetimibe, rather than having them take two different pills, Nexletol and ezetimibe. But here the biggest warning is gout, and the reason why is this, because of how it works. So bempedoic acid works here as a lyase inhibitor, ASCVL1, but down here in OAT2, when it blocks this cascade, uric acid goes up. So you can have a gout and then small, it was like 0.5% risk for tendon rupture. So you have to kind of think about that, make sure that you're clearly reporting possible side effects to your patients. But it's a very small risk, it's 0.5%. Just happens to be more than background, which is not taking bempedoic acid. So here it's important to see that it's about a 15 to 16% reduction in cholesterol, which translates here, ezetimibe alone, remember I said 18%, I usually tell my patients 20, or bempedoic by itself is 17, but together it's about 36%. I've actually seen it nearer 40 to 45%. And now we know that there are cardiovascular outcome benefits to it. Just hope to hear the actual details on it at ACC 2023. You can kind of see here the reduction when you do one or the other alone and then together. But here's the Clear Outcomes trial. 14,000 individuals were enrolled. You can see the population here. So it's always important to think about design of a trial, because that's how the FDA will approve this. Who will it be approved in? It will be approved in folks that have had ASCVD events, coronary disease, symptomatic PAD, or cerebral vascular disease, and then are statin intolerant. That's how the FDA will approve this, is my guess. And they will approve it to reduce CV death, non-fatal MI, non-fatal stroke, and coronary revascularization. So it's always fun to go back to a trial and say, how did they design it? That's how the FDA approval will be. So here are the assumptions. Again, this population, their LDL cholesterols remained above 100 because, lo and behold, they were intolerant to at least 2 or more statins. They assumed an event rate of about 4%, if we're rounding up. And then, in trials, you lose people to follow-up. They drop out of trials. But here, the power was to detect a 17% relative risk reduction. Remember that in high-intensity statin therapy, we expect a 28% relative risk reduction. In the Fourier and Odyssey trials, we saw a 15% reduction in events. Here it's 17%. So we'll see. We'll see what they ultimately come with, but they at least hit that goal. Evinacumab, I won't spend too much time here. I doubt folks here will be using evinacumab. Just think homozygous FH, if you've got LDL cholesterols 200 to 300 plus in the 1,000 range, this is one of the meds you're going to be using. But the interesting thing is how it works on ANGPTL3. There are now at least one, maybe 2 phase 3 trials looking directly at ANGPTL3 and then ApoC3. Here, just know that it works, right? It reduces cholesterol, and that's helpful in people who have homozygous FH, but we're talking about a 42% change when your LDL cholesterol baseline was 600. Now we're, yay, at 300, right? They still need plasma apheresis. Here, I think it's important to note that while LDL cholesterol getting to 70, that goal, magical goal, used to be 70, now it's 55, that folks above 70 had events versus those less than 70. That's why the guidelines used that in 2018, and now we have better evidence for getting less than 55. But curiously, triglycerides, anyone greater than 150 versus those less than 150, you saw that same separation. They are still at risk. If they achieved an LDL cholesterol at 70 or less, but still had a triglyceride greater than 150, they still had a higher risk of event. So it's important because then we talk about triglyceride lowering and what medications. Just so you know, I mean, a lot of things affect triglycerides, including not fasting when you're getting a lipid profile. But I do this all the time. I tell my patients I'd rather get the number than have you wait and then you forget to get the lipid profile. But there are a lot of things that affect it, so many modifying risk factors that we can address, including drugs for hypertriglyceridemia before we start adding meds. Here's the 2021 hypertriglyceridemia guidelines. I will just say this. You either think of pancreatitis or you think of ASCVD risk reduction. And that's the dichotomy. So the only thing in the ASCVD risk that I would say don't use first line, second line, third line, it's not going to be helpful, are fibrates. And lo and behold, prominent trial was just reported at the AHA 2022, and it was neutral. It doesn't affect ASCVD risk at all. They had to stop it for futility. So permafibrate, fibrate, fenofibrate, etc., it doesn't work in the statin era. Don't use it for ASCVD risk reduction. But if you're worried about pancreatitis, sure, you can use a fenofibrate or gemfibrozil, etc. So this is it. Statins are first line in all. Pancreatitis changes the conversation, but if you're looking for a reduction in ASCVD, do not use fenofibrate or fibrates. You're not going to get an ASCVD risk reduction. Again, fibrates on this side, I only mention it because of hypertriglyceridemia, but for pancreatitis, it's the omega-3 fatty acids that we now have data for EPA, eicosapentaenoic acid, and MACE reduction. So here it is. Icosapent ethyl is a purified form of icosapent ethyl is a purified form of eicosapentaenoic acid, EPA. And it's big. These pills are big. It's 4 grams. But what we found was in folks that have had MI or diabetes and their LDL cholesterol is well managed, but triglycerides are still greater than 150, if you add icosapent ethyl, you'll see a reduction in events for that group. And that was called the REDUCE-IT trial. Now, there's some controversy here. The controversy being the mineral oil comparator. It was the placebo. Folks think that perhaps that might have caused a little bit of harm. Well, I'll show you this. This is all the omega-3 trials. The top white ones are mixed dosing of EPA and DHA. And you can see the doses of EPA and the mix of DHA, all of them neutral. Meanwhile, the 2 major trials that we had, JELIS and REDUCE-IT, were EPA only and had 19 and 25% risk reduction, statistically significant. At AHA 2022, they reported out the RESPECT EPA trial. Now, the LDL cholesterol was very well managed, and they just missed their primary endpoint. Now, by the way, they were shooting for 30% risk reduction. I don't know why they thought that it would be a 30% reduction, but you can see very similar results here, 19 to 25%, and they just missed statistical significance, so we call it a neutral trial. But I think in the end, this adds to the thought that EPA is actually beneficial for MACE reduction. So no DHA there. I'll leave it up to you, Sharon. We're beyond the hour. We're in the kind of 6:30. So you lead me. I don't know if you want us to go through cases or if there are any questions that folks have.
Um, I will ask. I'm okay with. I think people love cases, but I think there might be some people with questions. So, Lindsay, do you wanna? She not here?
I advocate for you going through the cases
Okay.
and asking questions with that. I do have a couple of other questions, but they can certainly last till the very end.
Okay.
So for all of your expertise.
Yeah, so really there are only two cases that I wanted to kind of work through here, and one was to hit back at heterozygous FH. Here's a 42-year-old male, no history of diabetes, does not smoke. You know, you'd look at this blood pressure and say, oh, okay, is it elevated? The AHA 2017 guidelines would say, well, he's in that elevated blood pressure, but most of us would look at that and say, okay, we don't think that that's causing any major risk here. But his father suffered a heart attack at the age of 45. Man, if I'm 42 and I'm looking ahead 3 years, I'm a little worried. And so he comes in for today's consult, and lo and behold, look at that LDL cholesterol of 280. Here, family hypercholesterolemia, FH, family history of an event, young, 45 years old for his dad, his own LDL cholesterol is greater than 190. You have a clinical FH picture here. So he falls into that primary risk population that has an LDL goal of less than 100. So what happens? You start a statin. What are our goals here, right? The first is minimum greater than 50% reduction in LDL cholesterol. We want to target him to less than 100, and we know that there are only two statins, atorvastatin and rosuvastatin, and the doses are 40 and 80 or 20 and 40. So those are our choices to use with him. So we go ahead and say, well, you know what, we'll try rosuvastatin 40 milligrams. And in fact, you do so, and this is the calculation. It's the napkin calculation I do with my patients. I take it, 280, and then I minus 0.5, so 50% of 280, and you get 140. He's not even close to getting to his second part of the goal, but we've at least achieved a 50% reduction here. We'll say this is a follow-up, and he'll need some other therapy. So what is the next line? Well, we would add ezetimibe, right? So you add ezetimibe, and here again, 20%. Really, you'd get him to 112 on rosuvastatin 40, ezetimibe 10, and I'd say we're not done here. I really kind of leverage what the patient wants me to do. If he's worried, I'm worried with him. And in fact, the guidelines worry with him and say, we're not quite there. And in fact, the indication for PCSK9 monoclonal antibody is for someone that has heterozygous FH. I don't need to send him for testing. He meets the criteria. So I would go ahead and start Repatha. And if we know that it's about 50% reduction, you would say, well, from 112, we would get down to about 60 or 55, 56 milligrams per deciliter is what the back of the napkin calculation would be on Rasuva 40, ezetimibe 10, and then Repatha or Praluent added to this. Now, you know, if his preference is not to get an injection 26 times a year, right, every 2 weeks, but he'd just like it twice a year, then we could potentially argue with his insurance, because this is what would happen, is I'd have to do a prior auth and fight and appeal the denial after denial, and try to get him on it. But generally speaking, most insurers will say you have to fail the monoclonal antibody or some other side effect that they can't tolerate on the monoclonals before they can go to a small interfering RNA. Okay, so then the second one is our last case, but I think this is probably your usual, right? You have a 68-year-old woman with recent PCI. of your mid LAD and your proximal RCA. So this is a very high risk individual. She's over 65, but she also had acute coronary syndrome leading to subsequent PCI. So she's seen in post-hospital follow-up. She's on appropriate meds, all the antiplatelets and etc. But the rosuvastatin dose is 40 milligrams, and she reports new myalgias. So here we have someone that has a statin-associated muscle side effect, but her follow-up cholesterol, you're like, okay, there's a couple things I'm trying to manage here. First of all, she's very high risk, and we don't know her baseline. We can surmise that her LDL cholesterol is probably 160 because it's most likely had a 50% reduction to 80. But here, we don't know truly what the reduction was. We'll say that her LDL cholesterol goal, though, is less than 55. That's the new guideline, is to get her less than 55. But she has myalgia, so we have to kind of, it's not like I can add ezetimibe and add monoclonal antibody because she's having this side effect with rosuvastatin. So you may have to back off on the dose, and you say, look, do we have to totally stop this? Most will. I usually have patients back off to, maybe the lowest dose, which is 5 milligrams, or the next dose, which is 10 milligrams, and then let them kind of feel it out and see how they are able to tolerate it. And if we get to steady state there, then we repeat the lipids and then work towards adding ezetimibe and a PCSK9 inhibitor. But the lesson here is that she is very high risk, so her LDL cholesterol should be less than 55. And I guess I should have had this by chat, but I don't see the chat box because of the way I have my screen set up. But now open to questions.